Coming up on Why Should I Trust You? The big MAHA report is out. It's the game plan for how the movement plans to use the reins of government to rein in America's chronic health epidemic. Now that Kennedy and the Trump administration have laid out their plan, we'll dive in. Weighing in with us is Dr. Michael Forde, a public health expert and advocate for equality in health. Beyond the report, what does he make of the MAHA movement and what it means for Black Americans who are disproportionately impacted by chronic disease? Does he think they feel included in the MAHA vision? And finally, what will America's health system, its doctors, its public health workers, and scientists do to earn back the trust of a group that has historically had a lot of good reasons to mistrust? We knew September was going to be a newsy month, so strap in. Let's get started. Hey, everybody.
Yeah, welcome back, everybody.
Hi, guys.
Hey.
So, the news just doesn't stop. We're not doing any, summer, chill anymore. All that's over. Our last episode, we just want to thank our viewers. We heard from so many of you. You really listened. The episode of the folks who left the CDC with a group of MAHA supporters. A bunch of stuff, obviously went down at the CDC. You've got, Secretary Kennedy, who headed to Capitol Hill in a pretty fiery hearing. And then boom, yesterday, by the time this episode comes out, it'll be Thursday. But on Tuesday, we got the MAHA Commission report, the plan of action, the one that we've been waiting for. But first, guys, who are we? I'm Brenda Adhikari.
I'm Tom Johnson.
I'm Maggie Bartlett.
And I'm Dr. Mark.
Yeah. So as you know, Brenda and I are journalists. Maggie is a virologist at Johns Hopkins, and Mark is a physician and a medical reporter.
Yeah. And like we said up top, we have a really special guest with us. He's going to be riding shotgun with us throughout the episode. We are so thrilled to welcome to Why Should I Trust You, Dr. Michael Forde.
Welcome.
Awesome to be here with you guys.
So just a little background on Dr. Forde. He is a public health leader focused on public health equity. He is the director of health equity for a Fortune 500 health company where he works within the state of Maryland to improve access to care with a focus on Medicaid. And if you've spent, 2 minutes on TikTok or Instagram where he has hundreds of thousands of followers, you're likely to have seen his amazing videos chock full of history, science, and insights into the Black experience with health and America's medical system. And his handle is at Dr. Michael H. Forde. We are so thrilled to have you, Michael. So look, first off, we want to really talk about that big MAHA report. And Tom, give us a couple of basics just so we can get grounded here.
Yeah. All right. So roll up your sleeves. We're going in.
Rolled up.
Mark. So this is the MAHA game plan. And it's all about tackling chronic health among our kids. And you remember there was a report back in the spring. This is the part two. This is the MAHA Commission, which is not just made up of RFK Jr. at HHS, but it's got the heads of all of these different departments, like the EPA, Department of Agriculture, OMB, Stephen Miller's on it. So a whole lot of stakeholders. Not always with the same objectives and jobs, but they're all in this together trying to figure this out. And it's got 128 recommendations for action. So the first report got a lot of high marks from folks because it was all about identifying and highlighting root causes of the problem. Of course, public health would add to their list, but, they focused in on chemicals, ultra-processed foods, sedentary lifestyle of teens, on phones, things like that. Of course, they didn't get into, access to care, crushing food deserts, things like that, which are, of course, causes too. But they laid out this list and they got a lot of sort of bipartisan support for taking on these demons. So yesterday we got, what are we going to do about it? And RFK called this an existential crisis for our country. He said, there's never been an effort like this across all the government agencies. And that's likely true. This really is a cross-agency push to turn the massive ocean liner, which is the federal government, towards prioritizing chronic health in kids. There's a whole bunch of new targets of research, whether it's looking into ultra-processed foods or the chemicals in our environment. But at the same time, it's light on specifics. It doesn't lay out the funds and the money that it will take to do even a fraction of this. And the biggie that's not there as of now is new regulations on things like ultra-processed foods and chemicals, which the report did such an effective job of spelling out or driving our poor health. So we'll get into all that. But Mark, do you want to kind of walk through some of the highlights we've been kicking around here?
Yeah, I mean, there was a lot of anticipation about this report. Again, this is a report out of this new entity that Kennedy has carved out saying, look, over here at the CDC, you guys should just stay focused on infectious disease. A lot of this chronic disease stuff, we're going to form a new framework to tackle. So, I mean, if we look at some of the highlights of the action plan, look, these are like ideas. If you read this report, it's going to look like you've already heard everything before. So it's almost like a mission statement, a list, a laundry list. I mean, Tom mentioned 128 items. So the question isn't like, what are we going to do? It's more about, after I read this report, it's like, how's this going to happen? Who's going to pay for it? Like, it's a lot of ideas, but what has teeth? But let's look at the ultra processed foods mentioned. So the May report initially said that nearly 70%, and the studies show it's like 60 to 70% of children's calories now come from ultra processed foods. And trickle down effect is that causes obesity, diabetes, other chronic conditions. We've talked about that a lot on this podcast. It seems to be a universal agreement on all sides that, ideally we would eat less ultra processed food. And Tom's right. The new report doesn't roll out any new regulations on the makers of ultra processed food, but it does talk about something that we've talked about before, this so-called GRAS loophole. I'm not talking about cutting your grass. It's an acronym, GRAS, and it is a big deal. It stands for generally recognized as safe, and it means like what is in our food. A couple episodes ago, we talked with a former head of the FDA, Dr. David Kessler, about it. Essentially, what used to happen and what still happens is that food companies can add new ingredients and things into their foods, and they don't need to get like official approval. All they need to do is say, hey, we've got experts. Our science shows that this ingredient is generally recognized as safe. So if it was safe, it's good to go. We don't need to like prove it to anybody. Now, what the report is saying that the FDA, it wants to make the companies share that work. They need to show their work and show that that ingredient is actually generally safe or generally recognized as safe or considered safe or basically healthy for us. Now, we spoke with a friend of the pod. She's a chronic disease epidemiologist, Susan Main from Yale Public Health, and she was formerly at the FDA, and she used to study this stuff. She was the director of the Center for Food Safety and Applied Nutrition. She helped us understand. There's a lot of questions because this is like regulatory jargon, but she says that changing this process is going to take a long time to do. First of all, the industry could sue and say, look, we can't just do this. It's not practical. How long is this going to take? What about all the stuff that we're already eating? Are we going to like go back and take all those things off the shelf and have everybody prove it? Like, how is that going to work for our food supply and our food chain? I mean, this is like decades worth of ingredients. Will the agency hire teams? Like, how is this going to work? So this is something that is in the report, but, how do we move forward from this? Dr. Forde, do you have any thoughts about this idea that changing this GRAS loophole can make us healthier?
There is oversight, but at the same time, what does that oversight mean for public health implications? And so the way I answer this is I think that there have been efforts to close this loophole. I don't know if you all have looked up or read up those efforts, but in 2024, there was a representative that introduced legislation to require the FDA to incorporate certain restrictions on substances, such as those that would cause cancer or reproductive toxicity. So with that being said, and I don't necessarily have a definite answer for it because
no, we get it.
Well, let me just say one thing, because I know that in the last 24 hours, we've been talking to a lot of folks from public health, and I know that there's right now a tendency to sort of look at a report like this and find that it's, it may be a laundry list and it doesn't have teeth and whatever. But I have a slightly different take, which is, to me, reading a report like this, while I certainly, I'm craving more details and there's certain things that have been introduced before, I'd like to think as a country, we can get behind, and like that's our first thing that we can kind of push out. We can get behind an entire health administration that is prioritizing fighting chronic disease in this country. Like, to me, as a mother, I find that exciting. Closing the GRAS loophole is not a small thing. I understand that that is something that there is a lot of questions about. Other people have tried it, whether or not, Congress is actually going to even let this happen. And that's a big part of this. Congress right now, I think they would have to actually write a new law in order to make this even possible. But I just feel like we need to acknowledge that like this is something that people in public health have been calling for. This is something that people in establishment science have been calling for. And to have Kennedy and his team say, we are going to close the GRAS loophole, Yet, yes, we should hold him to account for that. But I think it's worth like giving him props for that. I think it's great that he wants to do that, and I'm cheering him on for that.
Yeah, I'm
And that was
surprised this one didn't get more pickup. You know,
Well, I think
it jumped right off the page to us. You know, we parsed every word of it, and it seems to be a pretty sizable deal. Like you said, it's a longer term battle, but in a report where there's a lot of aspirational things, this one seemed, especially on the hot topic of ultra processed foods, it seemed like it's a pretty big swing.
Yeah, it's not like they were saying we're looking into potentially closing the GRAS loophole. I mean, I'm just going to read the sentence. It said here, FDA will update regulations to reform the GRAS designation within the scope of statutory authority, which is an important caveat, by closing the GRAS loophole. Like, that was a very definitive statement. Now, we should hold them to it and make sure that that actually happens, but it's not as soft as some of the other things said. So I think that that's an important thing to just kind of pause and look at. I'm sure I'm going to get lots of folks in public health responding by saying that I'm missing stuff, but
I just want to jump in real quick if that's
Yeah.
okay, because
Yeah.
you know, you said a lot of important stuff, and just to go back to it, you know, the public health impact is definitely there, and you will have advocates and consumer groups, both alike, that will say the current system could be putting consumers at risk. They could be lacking transparency, and I think, but in contrast, right, when you look at the food and chemical manufacturers, they may claim that, oh, well, you know, this is necessary for innovation, and that's why, you know, at what point do we say the cost has cost us too much?
You know, the report, and yes, this has definitely elevated the discussion about chronic diseases. But I think I want to point out that just with mainstream public health, we do have a lot of common goals with what this report is about. But there's also the issue of making some assumptions. Like if you read like in the report, like I'm just going to search the term, like gold standard science, like pursue rigorous gold standard scientific research to help ensure informed decisions. You know, the framing of that is a lot of assuming that we haven't been doing that. And I think that's where a lot of mainstream public health has a problem with this. It's like
right.
this in a way is a form of gaslighting public health officials who say we have been doing this. Now, a lot of people, like, for example, Brenda, like you're now paying attention to this stuff because it has become so politicized. But the framework of public health and food safety and all of that has been going on at universities, at the NIH, at the FDA, at the CDC for years. I mean, and even this GRAS loophole. I mean, it's like a paragraph. You know, if you look about autism, it's autism. It's a sentence. If you look at vaccines, it's just like we want to, have improved vaccine injury recognition. You know, they're just like boom.
I know,
boom,
but
boom,
Mark,
boom.
are we really saying that like what our objection is that it's not like a 500-page detailed process report? Like, do we really think that that's what the public? Like, sure, let's absolutely hold them to account and like have conversations about how they intend to do this. But I personally think having a 20-page report listing kind of what you intend to do is way easier to digest for the public. And look, here's the one thing I'll say. I think I have a lot of empathy for folks in public health who've been like, we've been screaming about this for years. And I know that public health departments have been underfunded. Like there has been, like Kevin Hall came here saying that like back in the 2010s, his research into nutrition stuff was cut. But at some point, if you're not capable of winning over the public with the fact that you have been fighting for things, I think we also have to call that out. Like that's great that people have been fighting for this for so long, but like, has that fight been translated into a way that the public is convinced that the fight has been going on? Does that make sense?
It does, but I don't think the issue is that. I think it's the contradictions. It's you're putting out a report that says you're going to work on all of these things, but they're cutting Medicaid. So, or you want children to be safe, but you are really sowing doubt on, and more than doubt, really casting a lot of doubt on vaccines and what their role is. So it's a lot of the contradictions. Again,
well, that is such a terrific point, Mark, and that's something that I think, and I want to bring Maggie into this because I think one of the things I've been hearing is having conversations about expanding nutrition research, about all these big ideas to sort of learn more about pesticides and to learn more about how we can make our food better at the same time that we've had bigger cuts to the science and medical infrastructure, like the biggest drop in investment into science since World War II. Like, that is a contradiction. And I want to agree with that, Maggie.
Yeah, I think for me, this report strategy, it didn't mention viruses once. And I know I'm virus biased, I'm a virologist, but they're an important feature of health. Up to 1,000 children die every year from these common infections. And so they're not mentioned at all. But when you think about chronic diseases or things that affect you later in life, viruses cause cancers. And that wasn't addressed at all in this. The voluntary aspect of this and having companies voluntarily do things, I don't know has worked in the past. I think it sounds good, but it has to be implemented. And Brenda, I don't think it has to be hundreds of pages with 1 billion sources, but I'd like some citations. I'd like to be able to find some of the things of like, why are these the priorities and where is the data that supports that? I think the big picture is great. I think it's good to know where the strategy is, where are they planning to go, but I felt like there were things missing. And so I felt like it was kind of blind to the things that we know are contributors to chronic disease.
Michael, let me ask you from your perspective. This report doesn't really get into chemicals, pollutants, things that we know affect health. It says it wants to study them more, which we all sort of applaud. But it doesn't address chemicals. It doesn't address firearms, which is the number one, firearm deaths are the number one cause of death for children in this country. It doesn't robustly attack, food deserts, like we said. So source and access to fresh foods, these are things that have been cut. Low-income resources for purchasing of food has been cut. So there's just this brew that I think we're all wrestling with, which is, as Brenda put it well, this report's coming out on a backdrop of cuts to the things that it now is trying to raise up and say, these are priorities. So it's confusing, right? We have like this tangle of different interests. From your perspective, what do these objectives and this strategy mean for the Black community in America, which is, as we've talked about a lot, is so impacted by chronic disease?
Yes. Let's start going with the budget cuts. Let's just start there. Let's start broad. So we already know that the budget cuts have had a great, profound impact. When you look at the report, there is a conflict with some of the goals outlined, and then this need to have research done. So you have a conflict in infrastructure. So we already know the FDA now has more reduced capacity. We know that the CDC has some weakened public health infrastructure, and even the massive funding cuts that are happening within the NIH, where I used to work for 5 years. I used to work at NIDE, the National Institute of Allergy and Infectious Diseases. And then I worked at NCATS for the Center for Advancing Translational Sciences. And so you have a loss of expertise and instability that is happening. When we have this hindering of medical innovation with research and science, and you're asking, what is the impact on the Black community? Well, the impact is monumental because the Black community and other minority groups as well have suffered historically from the lack of taking research to focus specifically on them. Right now, we have Black maternal health is one of the leading causes of death for Black women. When you have the average Black woman is more likely to die from maternal related causes than a white woman. And just to be frank, a Black woman who is very educated and even has a college degree or master's degree, bachelor's or master's, is still more likely to have worse outcomes than a white woman with a high school diploma for maternal health. So we have the need for Black Americans to benefit from research and to benefit from research that is specific to them. I always think about health equity as a fine tailored suit, a bespoke suit, a suit that is made just for you. If I go into any store, Men's Warehouse, or the Brooks Brothers, I can't just put on a suit from the suit rack. I have to put on a suit that fits me. And just because it fits me doesn't mean it's tailored for me. And that's what healthcare is all about, making sure that the suit you have on is fit just for you. And so when you talk about Black America, for years, we did not have research that was specifically focusing on us. And now we finally have this momentum that's being built just to say, hey, you know what? We're not going to focus on maternal health for Black Americans anymore. We're not going to focus on rural health We're not going to focus on food insecurities. We're not going to focus on the food deserts that might exist in your geographic location.
What you're
So,
saying there,
yeah,
I just want to jump in because I think
sure.
it's important to underscore this. What you're saying is that those budget cuts for people in your community are basically saying you don't care about the things that affect our community.
I would say that. I would say that because part of caring is investing. And investing in the federal level means that I see that there's an issue with disproportionate effects on Black America. I see that, if I were to take away research funding, I'm exacerbating existing racial inequities. I am worsening economic security. I am making less opportunities available. And this impact is felt through job losses. This impact is felt through reduced access to vital services like healthcare, like nutrition assistance, and cuts to research that addresses health disparities. So you may not see the effect immediately, but over time, it is very possible to see more of the impact be negative for Black Americans who over time, we're benefiting more from advancement in research. For instance, I'll give you another example, sickle cell. So when we talk about sickle cell versus cystic fibrosis, even comparing the two, sickle cell primarily affects Black populations. But what's interesting is that cystic fibrosis, which actually affects less white Americans than Black Americans, has more funding. And this is something that it goes directly against equity for Black Americans and Black health research. 1 in 365 Black babies in America are born with sickle cell. However, when you look at cystic fibrosis, 1 in 3,500 white newborns are born with CF. Yet the proportion of funding is much greater for CF than for cystic fibrosis.
Yeah, so for sure. The other big headline that we were all texting each other about yesterday was what happened right after the report came out. So the report mentions pharmaceutical direct-to-consumer advertisement, and this is obviously a big issue for RFK Jr. After the report comes out over at the White House, President Trump signs a memorandum, and it effectively calls for like a return to the days in America before prescription drugs could be advertised directly to consumers, like on TV, which we all know is a major moneymaker for the networks. I mean, Brenda and I used to work. Mark still works with ABC News. We used to work at ABC News.
It was all pharma ads.
It just seemed like it was the majority of the ads they ran, right?
We would be like, if there was ever a non-pharma ad, like there would be cheers in the newsroom if there was like a car commercial, because everything else was like Humira, like Cialis, whatever,
Yeah, and this all fits into this theme of MAHA, which is America is over-medicating. The report cites that as a major driver of our issues. So the memo that Trump signs states that the ads can no longer, quote, recite a vague major risk statement and then point viewers to a website, toll-free number, or print insert for more complete information. Instead, they've got to lay out all the safety information in the ad itself, which I don't quite know how you do that in a television ad, but beyond what they've been doing now, which I think is like they split half of it's like vague things about how good the drug is, half is this kind of cryptic information is the side effects. But this very quickly is going to land in the courts. That seems to be everybody's contention, that pharmaceutical companies will claim a First Amendment rights, they'll sue. This will be a big fight. Again, it's another one of those that's sort of jumps off the page. I think people are still digesting it. Is this a fight the administration wants to have? I'm sure Kennedy wants to have it, but does the Trump administration want to have it? And again, it gets back to those unlikely partners in this crusade, whether it's the EPA, which has been rolling back restrictions on chemicals and pollutants, whether it's the USDA, which is trying to help a farming industry that's really hurting right now. And here, this would be taking on a big industry by an administration that likes to deregulate. So I don't know, Brenda, what seems like a really big stroke to us? I mean, what do you think?
Yeah, this is another one of those where I'm like, let's just step back for a second and realize that the United States and New Zealand are the only two countries in the world that allow direct-to-consumer prescription drug advertising.
Yeah.
Like, let's just think about that for a second. That means all the other countries in the world have recognized that there is something kind of weird about being able to directly advertise these drugs to consumers. So I don't want to sit here and defend this practice. Okay. I think it's a good idea to try to regulate this. We can talk about how difficult it will be to do, but I'm not here on some moral thing being all these people need to be in your television or your social media feeds selling their wares like it's fucking Coca-Cola. You know what I'm saying? So I think to your point, Tom, it's really about I'd like to see them gone. I'd like to see them totally gone. But the truth is, if you're going to actually just add in more caveats to ads that are already only 60 seconds long, and now what are you going to do? I was looking online and
but that may be the way to kill it, though.
It said something like already 30 to 40 seconds of the ads are listing the side effects. So now what? You're going to go up to 10 seconds of sales and 50 seconds of side effects. I just think we need to have a bigger conversation about why we're okay with pharmaceutical ads in our media. And if the answer is, well, this is really good for public health, you got to sell me harder on that, man.
I don't think
there's got to be a
anybody,
different mechanism.
Mark, I don't think anybody in public health really likes these ads, right? I mean, I think this is a pretty universal thing.
I mean, it's a way of life that we've gotten accustomed to. Doesn't mean it's right. It doesn't, but we all, we sing the jingles. We all know the Cialis ads. We've all heard it.
Can I just say with the Cialis ads,
I think
we all know the whole, they have the two cups. They have the couple in the bathtub. And then everyone is it's sexy time. And at the very end, it's if you have an erection lasting more than 4 hours, call your doctor. And it could result in death. And I'm like, okay, that killed the vibe.
I feel like this hits on the healthcare system here in America, because a lot of the ads are because we're learning about things that could be taught during medical training. And Mark, you might be able to answer this better, but for autoimmune conditions, I've seen a ton of ads for specific treatments. Ask your doctor about this, ask your doctor about that. And so it seems like a way to circumvent educating the medical community so that they have those options to treat patients.
I mean, we're not learning about these drugs through ads. I mean, they're there to sometimes raise awareness to orphan disease states and small disease states, but they're also there to make sure that, these blockbuster drugs become blockbuster drugs. But look, Donald Trump has his fingerprint on this, unlike the MAHA report, where I doubt that he, I don't know, but I don't think he read it. He actually issued a memorandum for the Secretary of Health and Human Services about these prescription drug advertisements, right? So it's coming not only from McCary making the announcement on X with a video, but it's also about, Donald Trump. This is something that they see as a target. But, at the same time, we have to remember, how does this actually happen? And are we treating every part of this industry fairly, right? So pharmaceutical drugs, have claims that they have to make, and all of these ads are heavily, lawyered up, and everything is approved by the language and making sure that they're sticking to what the FDA approval was about, and making sure that it's, the administration wants to ensure that everything is fair, balanced, and complete information for American consumers when it comes to these drugs. But now, if we're going to crack down on this, you also have to think about how you're going to crack down on all the supplement ads. Listen to any podcast, listen to Joe Rogan, listen to any of these podcasts. They are constantly bombarding you with this testosterone supplement and that testosterone supplement. Are they going to also use that same rule of law to those kinds of
Such
ads?
a terrific point. And I think, a lot of people have been sharing this Times video that really dug into the influencers. And look, I will say, I think the Times video was well done. I had some issues with its tone, and I found it a little condescending at times, but the $460 billion wellness industry is, I think, a really important thing to point out. I'd say folks in MAHA will say that the pharmaceutical industry is $1 trillion, but neither one of them, it's a lot of money both ways. And you're absolutely right that there isn't as much call to regulate the supplement industry from the part of MAHA. And I'd like our MAHA listeners to really think about that.
Yeah. All right. So in a moment, we'll be back with part 2 of this conversation. We'll have more on the MAHA report, all that's been going on with the MAHA movement, and a whole lot more of Dr. Michael Forde.
All right, welcome back. That was a good, juicy conversation up top, y'all. Okay, so Dr. Michael Forde, I want to ask you something just right off the top. We've been talking about this MAHA report. Do you feel, in speaking inside your community, do you feel as though the Black Americans feel seen by the MAHA movement right now?
No, I don't. I think that Black Americans, they feel maybe a bit understood, but not seen. And what do I mean by that? When you talk about the Black American community, you have to realize that there's been a lot of historical trauma, generational trauma when it comes to vaccines and vaccinations. And so the MAHA report wants to investigate more into vaccines and vaccinations. And the impact has been a lot of anti-vaccine talk around RFK and some of those states that are following that lead. And some Black Americans might understand that because when you talk about Henrietta Lacks, when you talk about Vertus Hardiman, when you talk about the Tuskegee syphilis study, there are historical instances where Black America could not trust the government. They could not trust the powers that be. They could not trust healthcare systems. But over time, the work needs to be highlighted that vaccines have eradicated a lot of disparities and closed the gap instead of widening the gap. And so I do believe you will have some Black Americans that might, as I said, they might feel like they're understood, but not quite seen. And the reason why I say not quite seen is because as I read the report, yeah, they mentioned food desert in one line, and you might have something mentioned about food security here or there, but who is benefiting? And you might say, well, Black Americans can benefit from the MAHA report, but what are we doing strategically to make sure that the benefits are not just going to be allocated to a specific demographic or geographic group? Because your zip code is your greatest health outcome indicator. Who are we truly targeting, and how are we truly targeting them?
Yeah. It seems that you are making the case very effectively, and it's a case that I think we all have digested over the years with our eyes being opened by folks like you, that for years and years and years, for decades and decades and decades, the American medical system, was greatly distorted by race and racism. The MAHA movement comes along and says, for years and years and years and decades and decades and decades, the American medical system has been greatly distorted by industry and money. So you're both, in a way, trying to take on the system and challenge the system. But to listen to your last answer, you diverge, right? And in a report like this, you're not seeing the Black community represented there. Like, is this a missed opportunity for MAHA?
Most definitely. Most definitely. Let's go back to what I said before. There's a lot of distrust that stems from historical and present day inequities. If you talk to Black Americans from all parts of the nation, you'll find that some are trusting of the healthcare system, but some are also not as interested as they could be. And 2024 Pew report actually stated that most Black Americans, a majority, believe that the healthcare system was designed to hold them back. So why do I say this? Well, there's a bit of discrepancy between MAHA's goals and the proposed policies. When you talk about potential Medicaid and Medicare cuts, when you talk about threats to social determinants of health, when you talk about attacks on, can I say this, DEI? Am I allowed to say that here? We talk about factors that actually potentially worsen existing healthcare disparities. And so if Black America is to benefit, I would challenge those who are working behind MAHA, those who are writing the strategy, those who are working on the methodologies, to line specifically how you plan, not just to help minority groups, but those who have been dramatically and disproportionately affected by policy, by geographic location, by the allocation of resources, and what are the effects of community-based solutions to make sure that we can address all those factors.
Yeah, Michael, I think what you're talking about is a way, like if we could just zoom out for just a tiny bit, maybe we can all make some progress, because the root cause discussion about what is the root cause of chronic disease is something that we all want. And then what you're talking about is not in contradiction to the root cause discussion. It's additive. And it's almost like the things you mentioned are the root cause of the root cause. Like it's all could be the same thing and a way to make progress.
Look, here's another thing I just want to bring up, Michael, and I want to get your take on this because, there's two factors at play here as I see it. I think you're so rightly pointing out that this, and I've heard it from many people, that this is a movement that for various reasons is not seeming to really be as much of a big tent when it comes to Black Americans as it may think it is. The one thing I find interesting is obviously if you look at polling coming out of this election, that President Trump almost doubled his support amongst black voters since the 2020 election. And like a third of all black men below the age of 45 apparently voted for Donald Trump. So what I want to get at is there seems to be something about MAGA and maybe even the MAHA movement that is sort of interesting to lots of communities in this country. And can you for a second think about what the narrative is that you see is resonating with Black Americans?
You're asking why Black Americans resonate with MAHA?
Like the through line in a lot of the MAHA movement's rhetoric is about mistrust of the system. And I'm wondering, is there something about that, mistrusting the system, that you see as resonating inside the Black community?
Okay. When it comes to mistrust and the Black community, I will start by saying that the report doesn't necessarily give Black Americans reason to create additional trust. And I think additional trust is founded by making people feel safe, making people feel heard, making people feel listened to. When you talk about things like reduced Medicaid and SNAP access or the elimination of health disparity programs, if they really understood what was at play, it would be very difficult for them to support some of the rhetoric that is at play. And the reason why I say that is because Black households are disproportionately affected in programs like Medicaid and SNAP, which is the Supplemental Nutrition Assistance Program. Now, some critics that have been very vocal, they may say, well, MAHA proposes cuts to Medicaid. They're going to replace it with some more beneficial factors that will help Americans be healthy again. But again, we have to realize that some of the mistrust that has been historical is still going to be at play when a lot of the individuals or institutions that could make food more healthy and accessible for Black Americans might not come to pass, right? Or how do we say we're eliminating funding for research and eliminating health disparity programs, but then saying we're going to increase the healthcare outcomes in those same areas? What do we get to? And also, what alignment has been made with Black organizations to further their association on enhancing health programs with the specific evidence of dismantling the barriers that have been preventing Black Americans from being more interested in healthcare and healthcare access? So,
Michael, let me ask you a question. We talk a lot about this moment of medical freedom, and a lot of Americans want to shake free of modern medicine. They don't trust it. They feel like it could be making them sick. I saw a video that you put out that was a very, very compelling story that I'd never heard about. And I wonder if I could just ask you to tell that story.
sure.
It was a story about something that occurred in the 1970s where there was a community, an African-American community, that had no access
Yes.
to modern medicine. This is just like 50 years ago. And Black doctors and nurses literally flew in to provide that help. I'd just be curious to reflect on that story, share that story, and just wrestle a little bit with this idea that we've got some Americans who want to get free of modern medicine and other communities that are trying to run to modern medicine. Please give it to
Right.
us.
Sure. So the story you're referring to is Cairo, Illinois. That's how you pronounce it, Cairo, Illinois. And in 1970, there were a group of physicians, a group of nurses, a group of college students, and they all happened to be Black Americans who said, in Cairo, Illinois, there are individuals who are not receiving healthcare access. And so these group of physicians and nurses and college students, they were in Chicago, Illinois. So they were in Chicago, Illinois, and they said, the best thing that we can do right now is to provide access where there is no access, because in Cairo, Illinois, Black Americans cannot access the clinics. They cannot access the hospital system because they were not allowed to. So you would have to go miles and miles away in order to get the access that would be provided because your skin color was appropriated in that setting. And so Cairo, Illinois was a very politically charged climate. There were a lot of protests against racial discrimination, and it was a very rough city. And so Dr. Berry, Leonidas H. Berry, he got his team of, as I said, college students, nurses, doctors, and would fly in small planes from Chicago, Cairo, Illinois, back and forth. And they used a Black church to house their medical treatments. And what was amazing about this story is that they turned the provision of healthcare into an act of resistance against systemic racism. And this team provided crucial medical care to the Black community that was not just needed, but it was specifically designated to the impoverished and predominantly Black community that, as again, they didn't have that access. So that story showed, sometimes when the system works against you, you have to create your own in order to get the most out of it. Now, when we tie that into today's story of health equity, and some people are running away from modern medicine, it's good to understand the history because there was a time when you were not even allowed to receive modern medicine. And now you have the ability to do so. Again, it's not an easy conversation with Americans, especially, I'm a Black American. So when I talk about America, I think about it in two standpoints: America as a whole, and then Black America, which is the community that I best relate to. But community-led solutions is the name of the game. And I think when you talk about that story, Tom, in the 1970s, the community-led solution was the way that Black America was able to build for themselves, fend for themselves, take care of themselves. The question that I actually pose back at everyone: is community and our community-led solutions the way that we answer this distrust in medicine in 2025?
Specifically on that, do you think that that's being done inside before any of this happened with MAHA and Kennedy? Do you think community-centered solutions are being lifted up inside public health in America?
I definitely do. I definitely do. Community-led solutions are actually one of the pivotal ground points in public health. We talk about culturally competent based care. We talk about culture and linguistically appropriate services. We talk about looking at who are the community leaders, whether it's clergy, whether it's local leaders at the business level, at the commercial level, at the healthcare level. But what I will say is there's always a need to match two things: the political climate that you're living in and the geographic area that you're living in. The political climate can definitely affect how funding, going back to funding, is appropriated for some of these community-led solutions. A lot of the times people have, historically speaking, picked up their own to lead their own movements with or without funding. But when we are in a time when certain words can't even be used anymore, I can't even say the word equity in some certain places. I can't say the word DEI in certain places. And I think that is concerning and alarming because we start to discredit some of those factors that can help community-led solutions be the most strengthening and be the most impactful. So yes, they have been done, and yes, they are still effective. But again, it's how effective are they, and what can we do to better this kind of momentum and this kind of movement in a day and era as such the one we live in.
Michael, you said something in a few minutes ago that really struck me. You mentioned Henrietta Lacks. She is the Black woman who, for people who don't know, she kind of changed medical research for all of us without even knowing that she did. Her story briefly is that she had cancer and her cells were used and collected and then used for research, and they're still being used today, but she didn't know that that had happened. And her legacy is an example of why there's such mistrust in, health research. And I wonder, because is it perhaps, the Black community and the advances that have happened because of that mistrust? Maybe you're ahead of the curve here, right? Because that, whatever happened there really did change medical research, informed consent, medical ethics, and actually increased, because there was that devastating blow to trust with her, that actually ended up, making investments in research, investments in, Black health issues that could impact the Black community. Is there a lesson there, like with what happened with Henrietta Lacks, what went down, and how that really changed now for the better for medical research? Is there a lesson there that could be translated into the MAHA movement, for example? Because they are also basing so much of what their positions are on the fact that there's so much mistrust. So what lessons can be translated?
Now, I love that question because we're going to get the party started. We're going to get the party started. First of all, I love talking about Henrietta Lacks because
it's a great book, by the way, for everybody.
Great book. I actually connected with the author of the Mortal Life of Henrietta Lacks, and that story revolves around patient consent and research ethics. So let's stay in this pot for a moment. Patient consent and research ethics. Patient consent. How would you define that, right? In simple terms, I would assume ensuring that communication flows seamlessly between the research party and the patient, letting the patient know about, first of all, do I have the permission to continue with this study? But then also I'm communicating to let you know what this study involves, how you might be affected, what are the risks, and these are some things that also are in the other pool of research ethics. She has the first and only, as I'm concerned, immortal human cell line. Her cells never die. They've been used for the polio vaccine, HPV, COVID-19 research.
Incredible.
So we talk about breakthroughs in disease research. We talk about the birth of modern informed consent. We talk about patient privacy and control over genetic information. And the MAHA movement, when we talk about, again, stay in the pool with me, of consent and research ethics, the question then becomes, have I included conversations with the communities that I'm trying to win over, but at a specific deep level? And for me, as a Black American, I'm specifically talking about Black America. And here's why. Let's go back again. Tuskegee, 1932, 1972. Henrietta Lacks, 1951. Exploitation during slavery. Forced sterilization, the story of the Rolfe sisters. I didn't even mention that. There were two sisters that were going into the doctor's office. They thought they were getting a normal checkup, forced sterilization. Never knew until years later. So how does this strategic report say that I've had these conversations with the communities that might be negatively impacted by some of these issues? I've had the conversations about the ethics related to how you might be impacted or how you might not even be included. Have you considered having conversations with more than just the baseline individuals that are in your company? And the reason I say that's because policy is only as effective as the people it serves. Policy is only as effective as the people it serves. Going back to the suit methodology that I brought up earlier, when you create something, you have to make sure that it's tailored for you, but it's also addressing all of your needs. So long story short, I think the strategy could really revolve a little bit more about the inclusivity of what it looks like to have impacts on communities for all of the factors that were mentioned in the report, but also having conversation. And I think conversation is really the name of the game. How do you have conversation to make sure that it is okay for me to support X, Y, and Z issue, and it's okay for me to have to weigh in without being and feeling excluded?
Michael, I gotta just that is such an incredible point that I almost just want to emphasize it and boost it again because, mistrust is a really unifying concept for many communities in this country. There are many communities in this country that mistrust the medical system. And what I'm hearing you say is right now, it feels like the MAHA movement is not doing enough to tap into those feelings of mistrust inside the Black community in this country. And by not really being as inclusive of that group, they're actually missing an opportunity to kind of build a movement centered around these feelings of, abandonment of a medical system, feelings of mistrust for a political system. Am I getting that right?
I would agree. I would agree. I would say that from a political and strategic standpoint, one could argue that the MAHA movement is indeed missing this opportunity to meaningfully engage with the medical mistrust that is prevalent within the Black community. And instead of building bridges, we can argue that the movement has rhetoric and policy stances that risk reinforcing that distrust. So, we have this idea of targeting institutions and not rebuilding them, or reinforcing some skepticism without addressing those root causes. We talked about root causes. Dr. Mark, we talked about root causes. And then I think the danger really lies in ignoring those specific inequities. The MAHA report, it does address things in the public health realm that should be improved. I won't discredit the fact that I agreed with some of the statements about the need to look at stress a little bit more on the impact of children, or the need to look at research when it comes to over-processed foods. But how do we look at things in a more socioeconomic standpoint to see what is disproportionately affecting certain populations? And I think when we have this broad scope of let's target this and let's target that and let's target this without really going deep into who are the people affected. And I remember, Maggie, you said you would have liked to see citations. I was looking for the citations and, looking for those peer-reviewed, very rigorously vetted citations. And I think when you think about the fact that the report sometimes ignores those specific inequities, it almost further undermines the trust building efforts that we just talked about, not just within the Black community, though, but within other communities as well that may not have been mentioned. And then we have this, is it okay to talk about, it is okay to talk about DEI, right? Like
Yeah.
I can, right? Because now we have this,
Michael,
this
I mean, we don't do that kind of shit here.
I mean, it's
Like, I think
crazy that
it's
you have to even
ridiculous.
ask.
Yeah,
you'd be surprised.
I understand that we're having like I wish we could have an important conversation about whether people feel like this is, an effective tool at racial reckoning, but the fact that people feel like they can't say it is ridiculous to me.
Well,
I mean, Michael, actually, I do want to know, do you feel like there are like places where you can't say that and feel
absolutely, absolutely, absolutely. Without putting too much of my information out there are certain organizations, institutions, and political entities where the mentioning of DEI or equity, and I'm a director of health equity, so let that paint the picture. It's not in conversational play. Going back to what we're talking about before, the broader political ecosystem around MAHA has been associated with efforts to undermine DEI. Now, in healthcare, DEI is very essential for addressing those systemic inequities, especially when it comes to increasing the diversity of the medical workforce, which in turn helps build trust in marginalized communities. So when I'm talking about the Black American community, and I'm talking about other marginalized communities, and I'm talking about communities who might even be minority groups, you have that contradictory approach where we're anti-DEI, we're anti-equity, we're anti, building safety gaps for specific groups in writing, but then we're saying we're going to do all these great things. And so my biggest takeaway for the MAHA report is this: there's some good there, but I would actually challenge all writers, strategists who wrote the report to go back, addendum if you must, but specifically outline who is impacted by factors, not just children, but racially, who is impacted? And then what is your plan to address that impact by community throughout the nation? I think once that conversation is had, it is a much better narrative that most Americans could have a conversation on, especially Black Americans.
Michael, that's a terrific point. I think it's a really good kind of like actionable item that you just threw out there. And one thing I'll just throw out there, because I'm sure you know that we have a lot of like listeners who are from the Make America Healthy Again movement, and we speak to them a lot. And one of the things, they are also not a monolith, just like Black Americans aren't a monolith, just like public health is not a monolith, whatever, right? Like we are all complex human beings here. And one of the things I've heard even from them is that they often differ from MAGA on some of their approaches, particularly when it comes to diversity. There are folks in the MAHA community I know who frankly aren't a fan of this kind of striking and censorship of language. One person I talked to is very supportive of the trans community, and he is a full-on MAHA supporter. And he's like, I don't really like what they're saying about the trans community in inside MAGA. So I just want to put out there that these are complicated discussions, and really that there's so much richness to it that is being kind of leveled in these pronouncements by the president. And I don't know that he necessarily speaks for MAHA when he's making all of this. So I just put that out there. Yeah, Michael.
And I just wanted to say something that just came to my mind, right? Because you're talking about the MAHA movement and how different individuals may have relation on one side and maybe not on the other. But building upon even what I said before, I do think that there are some concrete steps that could be taken by the MAHA movement to show that they're serious about addressing medical mistrust. And one of the things that I was thinking about just now is to fund, not just fund, but to elevate community-led initiatives to ensure that equitable access to healthcare is in play, to not be afraid to address social determinants of health, to foster diversity and inclusion. They don't have to use that terminology if they don't want to, but let's still play the same game, right? To foster that, because studies have shown that when you increase representation, especially within minority groups, you have more people willing to say, hey, I'll give healthcare a try. Not only that, you're talking about research and you're talking about doing studies again, right? To make sure that we are doing our research correctly. Well, why not promote patient partnership and reform medical research within the communities that might have distrust? To give them a little bit more of a, I see you, I hear you, I'm with you. That's all I wanted to say.
I love that. Maggie, you had
see
a
you.
point you wanted to make.
Yeah, I just wanted to underscore how important, and I love, Michael, what you brought up about community-led solutions. And I think the Black community did a just tremendous job during the pandemic addressing vaccine hesitancy within communities. While there's an underrepresentation for sure of Black doctors, they really stepped up and were addressing misinformation and holding community events. One of our former guests, Dr. Reed Tuckson, a friend of the pod, did a ton of that work in outreach. And I think it was so critically important to increasing the trust and the vaccine uptake during a really scary time for a lot of people. And I wonder what your perspective is and what you're seeing in the community now as all the rhetoric has been changing with all these different pronouncements. If you're seeing something similar, if that mistrust in vaccines is still high, and what you're seeing community-wise that's addressing it.
So community-wise, I would say the hesitancy is still high. And that's something, to be very honest with you, it's difficult sometimes to have that conversation because there has been so much distrust, historically speaking, that, I mean, you're talking about years of trauma. Years of trauma. So whenever I have this conversation about vaccine hesitancy with Black Americans, I always try to be understanding because they may have had personal instances and experiences that I may not have had. I've had vaccines yearly, COVID, flu, you name it, all the way up. So has my family members, but that's not every Black American story. But the main conversation around hesitancy outside of historical context and trauma is twofold. It's about trust in the healthcare institution, and it's about the concerns on safety and efficacy. So there is a level of trust with institutions such as pharma, government health agencies, health providers, but it is like a wave. Sometimes it'll go up, sometimes it'll go down. And it really just depends on perceived bias. And it also depends on the access to the healthcare initiative. During COVID-19, there were a lot of Black Americans who had distrust on vaccine uptake. And those that I interacted with who had successful vaccine uptake have shown an upward trajectory to be more involved in the healthcare system. However, those who had maybe a successful uptake, but family members had adverse effects or they had adverse effects themselves, the level of distrust was still there. And so this is where, Maggie, it gets to the conversation of how do we address misinformation and disinformation and then create an open dialogue for individuals to say what they want to feel, but not necessarily scold them for expressing their feelings. And I think as a public health professional, I was guilty of that for some time where you're telling me your personal experience, you're telling me your lived experience, and I'm telling you what the research says. I'm telling you what the studies say. I'm telling you what this peer-reviewed study that just came out on Tuesday stated. I'm not listening. And there's this gentle balance that needs to happen where listening and empathy has to be the key, but also reinforcing the impacts, positive impacts of vaccines, how they've closed the gap, and just laying it on the table, the risks of what happens if you are not to be included in such conversations and also actions. So it's a very complicated answer to a very complicated story, but the way that I want to proceed in 2025 and the future is to be engaged with community as much as possible, especially a lot of my online community, predominantly Black Americans, who they'll tell me sometimes, I don't trust my doctor, but I trust you. Well, hold on. No, no, no. Trust your doctor. That's a medical professional. I'm a doctor of public health. I am not clinically trained.
I'm not that kind of doctor.
I'm not that kind of doctor. The amount of messages I get, but it came to me that I understood the reason why some of those individuals were trusting, sometimes it's because I look like them, but sometimes it's also because I'm not afraid to say healing starts with knowing. I say that at the end of every video, because in order to move forward, you cannot forget the past. You cannot forget the historical trauma. You cannot forget the reasons why we feel the way we feel. And so when we have those conversations, I believe that Black Americans and Americans alike are more likely to listen a bit more to what you have to say. And for me, a win is not necessarily taking someone to the other side. I mean, that's the greatest win. Okay, if you are, saying, "Hey, I love the healthcare system. I trust the healthcare system," that's the biggest win I can get. But a win for me is I'm listening to what he has to say. I'm going to be more willing to do even my own research, but also exploring more opportunities to how I can get plugged in to the conversation and how I could be a part. And I think once we see more, and that goes back to the community-led initiatives and going to community and conversation are the answer.
Michael, I was just so moved by what you said, because what you're basically saying is that when you approach people who are vaccine hesitant, particularly in the Black community, you aren't judgmental, you aren't condescending, you're somebody who kind of looks at the whole picture, sees that there may actually be really legitimate reasons for them to mistrust vaccines because of history, because of trauma, because of lack of access to the medical system. And I just wonder if that same level of grace and empathy can be afforded to a broader swath of Americans who feel mistrust, but maybe don't often get the same scope of understanding from the public health community, because maybe it hasn't been rooted in the same historical traumas, but that people have their own experiences of mistrust anyway. And just because they can't say that it was rooted in the Tuskegee experiment or this or that, does that make their hesitancy any less valid? I don't know the answer to that. I just kind of put it out there that that's something that it could be the way you approach your community could be a lesson for doctors to approach all communities. And I do recognize there's bad faith actors who are trying to exploit systems. There are people who say things just to stir shit up. There are people who say things just to kind of not be helpful. I really get that. But there's a lot of people out there, Black, brown, white, everyone, who have questions and mistrust and skepticism. And I think a little grace towards those communities would be good all around.
I agree. And just to double back on your point, yes, it is very true that some groups and individuals outside of the Black community might still have mistrust, and they might still have this anti-healthcare approach. And we might not have the answers, Brenda, on what is the one thing that we could do to solve everything, to solve every problem, to solve everyone's distrust. I think part of the issue is there is a lot of information that's not always credible, but it's very accessible. I'm going to say that again. There's a lot of information that's not always credible, but it's very accessible. Social media has played a very dangerous game in healthcare outcomes where everyone's an expert. There are 10,000 Dr. Marks. There are 20,000 Tom Johnsons, 60,000 Maggies, 70,000 Brenda. Like everyone's an expert. Everyone's an expert.
You just put me in my place, Dr. Forde. There's 70,000 Brendas out there. I just feel I'm shook.
There's so many people who are experts by matter of way in social media. And so this countering of misinformation, I believe it starts with the respectful communication. So I loved your last episode, by the way. Everyone did a fantastic job because you had both sides who were having great discourse, in my opinion. And it's rare to see people of opposing viewpoints be able to really talk and conversate without attacking. That's the baseline for having these discussions, just starting with respectful communication. But it's just not based in research. Not all public health messaging is based on research. And I'm not talking about the public health messaging that I support, right? I'm talking about the fact that we have a report that just came out that stated more research has to be done on the research that has been done for the past 25 years. So how do we get to the point where both parties, Republican, Democrat, and all parties, Libertarian, whatever, Independent, how do we get to a point where we can all agree on scientific public health messaging that is proven time and time again without causing this need to create an even more shift and widen an even greater gap, in communities across America?
I mean, it's a great question. I think I'll take a stab at just one thing I'm observing in just doing the show. And it's that, look, we are in such entrenched media and sort of information silos that a big part of it that we find even when we're doing these conversations, and thank you so much for what you said about the last episode, but when we're doing these conversations between MAHA, between public health, between just folks who may not see eye to eye on some things, is that we're not really operating from a shared set of facts, right? That even agreeing on the terms of the conversation is quite difficult. And we get pushback all the time from our listeners. Why didn't you jump in when this person said that thing? And this goes across the board from MAHA, from public health. Why didn't you jump in when this person said that thing? And I think, what I'm finding, of course, in the work we're doing is, a big part of why we want to do this conversation or do these conversations is because we actually want to find out why people feel the way they feel. And it's not just trying to set up a sort of debate where everyone's like in hand-to-hand combat trying to like say, no, you're wrong about this. And I have a study that shows this. And no, you're wrong about this because I have a study that shows this. But it's to actually, in a civil kind of a arena, try to even just understand where people are coming from and why they feel the way they do. I know that can be a really frustrating approach to people, but for me, the biggest challenge is when you've got 2 or 3 sets of people who are like, well, I have my facts and I have my facts. And that, I think, is one of our biggest conundrums in our society today. Tom, I don't know if you want to weigh in on that.
I have my facts, you have your facts, and my department has its data. And the old department had its data. Like, if we start to lose that, we really lose the thread. But Michael, I just want to end on sort of a really fundamental point, because we can talk about trust and we can talk about community leaders and we can talk about all of this. But if somebody doesn't have access to a doctor, if someone can't get preventative care, then we as a country are going to get a lot less healthy, as much as that's hard to wrap our heads around, because we just diagnosed in this MAHA report how unhealthy we are currently. When you step back and look at this moment, where would you place the Medicaid cuts in funding and the work requirement restrictions that really universally everybody says is going to plummet the number of people with access to preventative care in this country? Where do you place that as emblematic of where we are as a country and where we're heading when it comes to getting healthier?
Tom, I will say that it doesn't place us in the best position. There have been many conversations that I've been a part of, and it makes me sad, which is why I took a deep breath before I even responded to you, because those who are impacted by Medicaid cuts are vulnerable populations. Most people don't know this, but children make up one of the highest population enrollments of Medicaid, followed by women. And the age range for most individuals on Medicaid are between the ages of 18 and 35. So you have individuals who are trying to make it. They're trying to deal with what life has given them, so to speak. And the impact gets even more dark, just to be very frank with you, when you consider that the individuals that are impacted may not have access due to geographic restrictions, due to certain determinants of their care, such as, do they live in an area like, for instance, Georgetown, DC, or Southeast DC? Do they live in an area like, for instance, Raleigh, North Carolina, or let's say they live in Lillington, North Carolina, which I was in both places. One is more urban, one is more rural. How does the impact of rural health now factor onto the Medicaid cuts, factor onto all these social drivers of health? Sometimes people say not determinants, because they'll say, these are factors that would drive your health outcomes. So there is a negative impact. And I think we have to come to the reality of that while this impact is negative, the most important thing to do, in my opinion, is to advocate. Advocate means you become well informed on how you can voice your opinion. You become well informed in how you can speak to your local city and state leaders. You become well informed in how you can create a narrative that is not just fact-based, but is also needed for individuals to speak out. Because when you don't include community and don't think of community in such conversations, you create a gap that over time becomes wider, and you have worsened health outcomes, you have more strain on healthcare providers. So all this to say, it's not an easy answer, but it's a dark answer
It's
in
the
very
lesson of Cairo, Illinois. Again,
yes.
community has to take care of itself.
Yeah, yeah.
Well, listen, I just want to thank Dr. Michael Forde for joining us in this conversation. He is a leader in the public health equity space. And also check out his social media accounts on TikTok, on Instagram. Are those the two main ones, Michael, Dr. Michael H. Forde?
I also just created a YouTube, so check me out on YouTube as well. Same thing, Dr. Michael H. Forde.
Amazing. Yeah, his stuff is great. He has hundreds of thousands of followers. That's where we actually found him. Somebody flagged his work to us and we listened to his stories and we were really moved by them. And we were like, we got to get him on the show. So a huge thank you to Michael Forde. I am Brenda Adhikari. He is Tom Johnson. She is Maggie Bartlett. He is Dr. Mark Abdul Malik. Please send us questions, comments to questions@whyshoulditrustyou.net. You can also check us out on Substack. We'll probably have a post out today or have one out already. And thank you. We'll see you next week.